Okay, so we are going to go ahead and get started. We want to first of all welcome all of you to another one of our Jiann-Ping College of Public Health here at Southern in the Office of Practice and Research. And this is one of our grand rounds. And as you know, our focus on the grand rounds is actually to invite both our faculty, staff, students, and the community to learn about the great work that's being done here locally, as well as nationally and internationally. And so today we actually have a very distinguished faculty member, Dr. Bettye Apenteng, who is an associate professor in the Department of Health Policy and Community Health. And Dr. Apenteng will speak about her and her colleagues' experiences in the vital work that they're doing with the rural hospitals, particularly in our area. And I am very, very sure that we will all learn something from this. So I would encourage you to look at the agenda. We will first have this introduction and welcome, and then we will also then move to Dr. Apenteng presenting her presentation. We hope that at the end of her presentation around 12:45 or so that you will have questions for her, and then we'll wrap up with a brief debriefing on the seminar itself. So without further ado then, I want to welcome our distinguished guest and speaker, Dr. Bettye Apenteng, and I will ask that we drop our share screen for the agenda and then let Dr. Apenteng share her slides, and then we'll go from there. Oh, as a reminder, by the way, we are recording this, so we'll have this recorded, as well as we will request Dr. Apenteng to share her slides, and then we will post all of this on our Office of Practice and Research website for you and follow up and review. Okay, Dr. Apenteng, without further ado, you're on.
Thank you so much, Dr. Telfair. Welcome, everyone. Thank you for spending your afternoon with us here at the Jiann-Ping College of Public Health. Today, I'm going to be presenting work that, as Dr. Telfair said, myself and a team of colleagues have done focused on Georgia's rural hospitals. So the title of the talk today is Keeping Doors Open, a look at Georgia's efforts to save rural hospitals. So like I said earlier on, the work that I'm presenting today is a team effort, and everything that is being presented couldn't have been done without Charles Owens, Angie Peden, Linda Kimsey, Samuel Opoku, William Mays. And together, these individuals represent a team that is focused on rural health systems research and practice here in the state, but also regionally. Collectively, we have done a lot of work working directly with rural hospitals, including needs assessment, strategic planning, and are currently working together on the Flex Financial Operational Improvement Grant. There are other faculty members who have participated in some aspects of the project that I'll be discussing today. Notable among them is Dr. Ramona Lawrence and Dr. James Stevens of blessed memory. A lot of what we do here at the college is pivoted on students, and student mentorship is taken seriously through the Center for Public Health Practice and Research. Work that is being presented today has had student involvement, including some who have graduated. Emmanuel Akowa, who's currently at Baylor University, has been instrumental in some of the work that we're going to be discussing today. Emma Obon Ekpo, Michaela, Heisen, Lola Onifade, Bleda Shehaj, Anna Rosa Moore. I may have left a few people on here, but if I did, I sincerely apologize. We certainly take student mentorship seriously in the work that we do. So the setting of our discussion today is in rural America. And this is an area that houses 1 in 7 Americans, despite making up 97% of the country's land mass. When we talk about rural America, there are significant stretches just beyond the geographic expanse of the area. Rural communities contribute significantly to the US economy, especially when we're thinking about agriculture and the manufacturing sectors. They are also leaders when we think about startup businesses and entrepreneurship here in the United States of America. Despite these significance, however, rural communities experiences many challenges that is of no news to a lot of people who live in rural areas or who have done work with rural communities. Notable among these challenges is a decline in population growth, higher poverty rates, a decline in economy, lower levels of educational attainment, and lower labor force participation rates. All of these things are driven in part by a primarily Asian population in rural areas that limits the amount of working adults who can contribute to the economy. These challenges affect health and well-being. Those of us in public health are well aware of social determinants of health and the impacts that they have on healthcare outcomes. So in rural areas, they notably experience poor health outcomes, and this is exacerbated by limited access to health promoting resources, including healthcare professionals. There's also limited access to healthcare services in general, of note being specialty healthcare services. A lot of these resource limitation is compounded by the fact that there is a higher prevalence of less health promoting behavior, including smoking, obesity rates, physical inactivity rates, which tend to be higher in rural populations. They also have limited access to healthcare coverage with high rates of uninsured and underinsured populations. So that is the national picture, but in Georgia, the rural story is really no different. The tale of two Georgias has been well documented, and this sort of highlighting that economic and health gap between rural and urban areas. And research has been looked at this since as far back as the 80s. Very recently, the Healthcare Georgia Foundation, in recognition of these persistent disparities, started the Two Georgia initiative to really draw attention to the disparities in economic and health outcomes between rural and urban areas in the state of Georgia. In rural communities, rural hospitals are sort of the hat or the hub of the community when it comes to healthcare and healthcare access. In Georgia, rural hospitals are defined based on critical access hospital status and population size. As you can see from this map, the majority of counties in Georgia are classified as rural counties, and the state uses a population cutoff size of 50,000. So counties that have less than 50,000 are designated as rural. And hospitals that are located in these communities and those that have a critical access hospital status are defined as rural hospitals. In Georgia, there are currently 61 rural hospitals. 30 of them are critical access and 31 are non-critical access rural hospitals.
I'm just telling you how it looks from my perspective. And then I understand everything.
Critical access hospitals are distinct from other rural hospitals in that they are reimbursed based on a cost basis. And so they get reimbursed 101% of their cost. They are characteristically small, having only 25 beds or less, and tend to have a average length of stay should be no more than 96 hours. So when we think about rural hospitals, they are really important community assets. Not only do they serve as the healthcare provider for emergency, primary care, and tertiary healthcare services, but they are also oftentimes economic drivers in the communities within which they are located. They are often one of the largest employers in the community, and their presence sometimes improves the attractiveness of the community to industries and businesses. However, there has been an ongoing crisis, and rural hospitals are largely becoming an endangered species, so to speak. Since 2010, 138 rural hospitals have closed nationwide, with closures reaching a record high in 2020. So understandably, there has been renewed attention to rural hospitals and rural hospital closure. And this attention is needed and warranted because rural hospital closures tend to reduce access to quality and timely healthcare services, particularly for vulnerable populations, and they tend to further worsen the economic states of rural communities. So some of the access consequences of closure include reduced access to emergency care and primary care, as well as reduced access to specialty care services. When hospitals close, healthcare providers tend to leave, and so this further limits the access to healthcare services that particularly vulnerable populations may have, including those that are elderly, minorities, and populations who do not have access to transportation to leave the community to seek healthcare elsewhere. Because rural hospitals tend to be economic drivers, when they close, communities tend to lose jobs, and they also experience difficulties in attracting industries and companies into the rural community, further worsening the economic prospects of the community. As I stated earlier on, since 2010, there have been 138 hospital closures. And you can see that we reached an initial peak of closures in 2015 with 17 closures. That declined significantly between 2015 and 2017. Now, since 2017, we've seen an increase in hospital closures, and we have now reached a new peak. Hopefully, this is the peak at 19 closures in 2020 alone. Now, there is a geographic pattern to these closures. We're seeing a lot of congregation or concentration of these closures in southern states, including Texas, Georgia, Alabama, Mississippi. And these are the states that have been most significantly impacted by rural hospital closures. In Georgia, we experienced a peak of closures in 2013, where we had about 3 closures. Now, we had a period between 2017 and 2018 where we had no closures, despite an increase in closures nationwide. But unfortunately, in 2020, 2 hospitals closed, perhaps in part because of the COVID pandemic sort of making an already terrible situation, financial terribly situation worse for those hospitals. In terms of a geographic pattern, 3 of the most recent closures have been clustered in the southwest region of Georgia, an area that has a history of limited access to healthcare services and low socioeconomic status. So we know that 138 hospitals have closed nationwide. However, there are several more hospitals at risk. 453 rural hospitals are at risk of closure based on data from 2020. Of these, about half, 216, are considered most vulnerable, meaning that they are at the highest risk of closure. In Georgia, 18 hospitals are at risk of closure, 13 of which are considered most vulnerable. So these hospitals, 453, represent 21% of all rural hospitals in the state and 27% of all rural hospitals in the state of Georgia. Now, rural hospital closures are primarily driven by operational and financial vulnerability of the hospitals. As this set of charts show, rural hospitals tend to perform worse financially in comparison to urban hospitals, despite actually performing better when we're looking at patient satisfaction measures. So if we look at this first image, at least to my left, that shows, the graph shows high-performing hospitals and low-performing hospitals in the US in general. And you can see that a higher proportion of urban hospitals tend to be in that high-performing category, with about 53% in that category, compared to only 29% of rural hospitals being classified as high-performing. In terms of definition, a high-performing hospital here, for the purpose of this figure, is defined as a hospital that reports profit for 3 consecutive years, whereas a low-performing hospital is defined as a hospital that is reporting losses for 3 consecutive years. And as you can see here, a higher proportion of rural hospitals nationwide tend to fall into this low-performing hospital category, 38% versus only 22% of urban hospitals. In Georgia, it's actually a little bit worse. As you can see, 46% of Georgia's rural hospitals tend to fall in that low-performing category, compared to only a quarter who fall in that high-performing category. So why are rural hospitals struggling financially? This is in part due to low volume. As we know, rural communities tend to have smaller population size, and it is further exacerbated by the declining or slow population growth in these areas. There's also declining reimbursement, particularly government reimbursement. For example, there's been sequestration. Medicare, their proposed Medicare cuts actually coming up to about 10% for some providers. And this tends to put rural communities at a disadvantage. There's also increasing competition. And this fuels bypass behavior among rural residents who tend to bypass their own local hospitals and go to larger urban centers. As we stated earlier on, socioeconomic conditions in rural communities tend to be worse than urban communities, leading to higher levels of uninsured rates, higher poverty, and higher unemployment rates, which makes those markets tend to be less economically favorable for companies and organizations that are located in those markets. And this is no different from hospitals who operate as businesses in these markets. Rural hospitals also face provider recruitment challenges. It's very difficult for rural organizations to attract and retain physicians and other healthcare providers. And this impacts especially specialty care, the presence of specialty care in rural communities. In 2017, our team conducted a national survey of rural hospital executives, and they identified declining reimbursement, poor payer mix, and poor payer mix here refers to a high level of uninsurance, and regulatory requirements, as well as physician recruitment and retention as the top 4 threats to their financial stability. And it was fairly consistent between Georgia and other states, even though Georgia tend to report a higher proportion of Georgia hospital executives tended to complain a little bit about the payer mix, the high levels of uninsured rates in the state. We also conducted, as part of the study, interviews with Georgia rural hospital executives. And the emergent themes that were identified during these interviews really highlighted the challenges in operating a business, and operating a healthcare organization in a community context that is significantly affected by low socioeconomic and healthcare challenges. The healthcare executives sort of documented the fact that the threats that they face to financial sustainability tends to be pervasive and consistent, and that all of our rural hospitals were facing similar conditions when it comes to the low SES, when it comes to high level of uninsurance, when it comes to the challenges with dealing with a decline in reimbursement. They stressed the fact that balance was essential. So in basically coming up with health planning and figuring out what type of services to provide for their communities, they always talked about how they had to navigate community needs with financial considerations, trying to figure out, yes, the population needs this service, but can we afford to provide these services? Do we have the resources to provide these services? Or if we do, are these services going to put that as a financial risk, or are they profitable? So they always have to sort of navigate these considerations when it comes to healthcare planning. They talked about the importance of a multi-sectoral, multi-level intervention to sort of ensure that rural hospitals are financially sustainable. They called in part for community members to help by using local healthcare services and not sort of leaving the community and seeking healthcare elsewhere. They also called for government intervention at the federal level, the state level, and the local level. They really called for support at those levels. So the state of Georgia listened, and in 2015, the then Governor Nathan Deal commissioned the Rural Hospital Stabilization Committee, and their charge was to identify the needs of rural communities and to provide some recommendations for addressing those needs. So as part of the recommendations of this committee, they suggested that the state dedicate money to fund a rural hospital stabilization pilot project. And so as part of this project, which was implemented in 2016 by the state of Georgia, rural hospitals who participate in the project receive grant funding to implement programming or services with the aim of basically enhancing access to quality healthcare services for rural residents. So hospitals that have participated has implemented interventions to prevent the use of emergency departments as primary care access points, and actually to redirect people to appropriate settings of care. They have implemented projects that integrate telemedicine to maximize access to specialty services. And collectively, these programs are also designed to minimize negative financial outcomes to the rural hospitals. As of 2020, 22 hospitals had participated in the program. Participating hospitals share $3 million every program year. So if there are 10 hospitals that are participating, each will get $300,000. So the actual amount of money depends on the number of hospitals participating and maybe the programs in which they are proposing as well. Now, state level efforts did not stop with the stabilization program. The Rural Hospital Tax Credit Program was also created under Senate Bill 258 in 2016, and it went into effect January 1st, 2017. The Rural Hospital Tax Credit Program has an aim of improving the financial sustainability of rural hospitals in the state. What the program does, it allows taxpayers who file as individuals, married, or as corporations to receive tax credits for any contribution that they make to a qualifying rural hospital in the state of Georgia. Single individuals and those who are married and filing jointly can claim 100% of the donated amount up to $5,000 and $10,000 respectively in their state tax returns. Corporations can claim the lesser of 100% of their contributions or 75% of their state tax liabilities. State tax to the contributions to the program are capped annually. And for the program year 2021, the cap was 60 million. And in 2020, there were 58 eligible hospitals who were participating. I apologize, this is a typo. In 2021, I believe there were 56 hospitals that were eligible. The donations that hospitals receive from this tax credit program can be used for operational expense, to pay debt, for capital improvements, to purchase equipment, to invest in clinical care as well. So who qualifies? To qualify to be eligible to receive money from the tax credit program, the rural hospital has to be a critical access hospital or a rural hospital per the definition of the state of Georgia. They have to be a nonprofit hospital that files an annual IRS Form 990 or a Department of Community Health equivalent. They have to participate and see patients in both the Medicare and the Medicaid program. They have to be current with all their audits that are required by federal and state law. They have to provide care to indigent population and have at least 10% of their annual net revenue being categorized as charity care or indigent care or bad debt. So the tax credit is one approach. There's been several other rural-focused policies and programs that have been implemented. Notable among them is the Rural Hospital Leadership Training. It's a state-mandated training that uses approved curriculum for health hospital executives and board members. And the whole idea is to ensure that all of these leaders in rural organizations tend to have a basic level of training on their fiduciary capacity and on just basic healthcare management principles. Our team here at Georgia Southern, led by Charles Owens, in partnership with the Georgia Hospital Association, is a state certified trainer, and we train rural hospitals as part of this program. The state also designated funding to Georgia Rural to develop a Georgia Rural Health Innovation Center. This center is currently housed at Mercer University, and they are charged with really leading research and innovation in coming up with ways to improve rural healthcare access and rural healthcare outcomes. So for the rest of this presentation, I want to focus a little bit more closely on the Georgia Rural Hospital Tax Credit Program. And I'll be presenting a series of studies that our team has conducted to kind of evaluate the impact of this program. You're going to be seeing the Georgia Rural Hospital Tax Credit Program being used interchangeably with the term Georgia Heart Program a lot. And that is because the Georgia Heart Program is it's essentially the same thing. It gets the name Georgia Heart because of the third-party administrator who administers the program. So when you see both, they're referring really to the same program. And the HEART is an acronym for Help and Enhance Access to Rural Treatment. So in the first series, the first of the series of studies was a qualitative study examining the perspectives of rural hospital executives on their thoughts about the tax credit program. So we interviewed 21 rural hospital CEOs in the state of Georgia, and that represented 36% of eligible rural hospitals. And overall, this study identified favorable perceptions about the tax credit program among Georgia rural hospital executives. And as one hospital executive summarizes, he or she basically says, it's been a game changer for us. I think the biggest reason is because we have several capital and infrastructure needs. It's hard to make decisions when you have 2 to 7 days cash on hand to work with. But with the Georgia HUD program, we're able to fund our needs. Now, the themes that emerged from our discussions with these hospital executives, I think one of the biggest things that emerged was that these executives felt that the tax credit program was a valuable lifeline for rural hospitals, especially those that were really struggling and were on the brink of closure. They have been able to use this money, the donations that they receive, to support operations and growth. They also are hoping that through the tax credit program, they are able to cultivate a sense of community ownership of their local hospital, and that they're hoping that if people donate to the hospital, there is an increased sense of buy-in and ownership, and this would allow them to utilize the hospital a little bit more and work towards improving that sustainability of the hospital. They, however, complained about some bureaucratic and fundraising constraints that sort of limited their ability as rural hospitals to maximize the program's benefits. One of it was actually fueled their use of this third-party administrator, which is Georgia HUD. A lot of hospitals complained that they didn't have the internal capacity to be able to focus on raising funds and sort of cultivating donors and soliciting donations. And so they all outsourced. As of 2020, almost all hospitals were using the Georgia HUD program to do that fundraising piece of the program. The hospital executives were hopeful about the program, but they were cautious about the program's future. All of them want the program to basically exist for a long time, but they're not sure that that will be the case. And so in the meantime, though, they requested that the state makes changes to improve transparency of who gets the tax credit, how much, and certain things to sort of streamline the donations to make it easier for donors to donate and improve the program's efficiency. So it's been almost 5 full calendar years since the program has been in place. So has it really helped? The qualitative gave us sort of some formative perspective of the impact of the program, but to really see the extent or quantify the extent to which the program has been beneficial, it required an empirical examination. So in the next study, we did exactly that. So we conducted a quantitative policy analysis to look at the effects of the program participation on the financial health of rural hospitals that participated in the program. And so we looked at data from 2015 to 2019, with 2019 being 2 years since the program has been implemented. And we used data from the Centers of Medicare and Medicaid Services to answer this question. For those of you who want to read more details about this study, it's published and publicly available, and you can sort of download and read at your leisure. Now, I don't want to go into the methodology, bore you with that detail, but I do want to highlight the broad approach that was used for this policy analysis. We use a difference in differences approach, which is a common methodological approach for evaluating the impact of policy. So when we think about the tax credit program, which was implemented in 2017, when you are doing a sort of a DID or differences in differences approach, you want to be able to get data that happened before the policy was implemented and data that happens that you collect after the policy was implemented. So for our pre-policy period, we use 2015 to 2016, and for our post-policy period, we use 2018 to 2019. So in a DID, obviously you have your intervention group. In this case, it's rural hospitals that are affected by the tax credit program. We collect baseline data that measures financial health in the pre-policy period, and then post-implementation data that assesses financial health after the policy has been implemented. If you want to look at the effect of the policy, one would think that, well, maybe if we kind of subtract or look at sort of the changes from T1 and T2, that could be the effect of the policy. However, that may be inaccurate, and it's inaccurate because there could be other things that are happening in the market or other things that are just happening over time that tends to make hospitals in general perform either better or worse, which is why a comparison group is needed. So what the comparison group does, it allows you to tease out the noise. It allows you to tease out those sort of background things that could have happened regardless of whether the policy had been implemented. And so we take a comparison group of hospitals, and we also measure them financial health at pre-policy and repeat the measurements at post-policy. So your difference in difference estimator, in simple terms, is really taking the impact up here and you subtract any changes from the control group down here. In practice, however, we obtain that estimator by taking the slope of the interaction between the time period and the program participation period. So this is sort of the general analytical approach that we use to assess or evaluate the impact of the policy. Now, one of the key assumptions that the DID approach has is this whole concept of parallel trends assumption. And the parallel trends assumption basically says that your comparison group and your intervention group have to have a parallel outcome. So their outcomes have to be parallel in nature. It could be identical, and that would be great, but it doesn't have to be identical. They just have to be parallel. So when you look at this figure to my right here, you can see that the slope here is parallel between A and B over here. And then if the policy happens here, if you see any divergence, you want to assume that had the policy not happened, the parallel trend would have continued. But if you see a divergence, then you can say that this divergence from that parallel trend is due to the policy. So selecting of control states or comparison states becomes very critical. For our study, we identify states that surround the state of Georgia. They are all southern states. They have similar healthcare outcomes in terms of social determinants of health, healthcare outcomes, but they are also similar in terms of the market conditions within which hospitals operate. All of these states represent Region B, which is a regional designation used by the federal government, the HESA agency, for their hospital-specific programming. Kentucky is part of Region B. However, we excluded Kentucky from our study because Kentucky has expanded Medicaid, whereas all of these states have not. So to ensure that the market conditions are identical, we excluded Kentucky from the comparison states. So our final study sample included a balanced panel of 136 hospitals. So the balanced panel simply means that we obtained data for each hospital for every year that we looked at. So for 15, 16, 17, 18, and 19. And so there were 47 of which were Georgia rural tax credit recipients and 89 that were comparison hospitals. To be selected as a comparison hospitals, not only did the hospitals have to be located in one of these 6 states, but they also had to meet the criteria for tax credit participation, for which we had data to evaluate. So they had to be either critical access or a rural hospital that is located in a county with fewer than 50,000 residents. They had to have taken part in the Medicare and the Medicaid program as well, and they had to be nonprofit. So to assess financial performance, we looked at measures of profitability, looking at total margin, liquidity. We looked at days cash on hand, which is basically how many days the hospital can survive if they didn't have any money coming in. We looked at debt to asset ratio, which is basically the extent to which the proportion of their assets that is financed by debt. So higher levels here is not good because it means that they have more debt. We also looked at the financial age of fixed assets, which is, we looked at average age of plants, which basically in a sense measures how old the hospital is and whether or not they have up-to-date equipment in that respect. That is sort of captured in that measure. We also then combine these 4 measures into one composite score using a well-known index, financial strength index, the Cleveland-Lees Financial Strength Index. Now, because the effect of the the tax credit on financial performance happens through donations, we first had to establish that the policy was associated with an increase in donations to rural hospitals before we could look at these other financial impacts. So first, we also had to confirm that our parallel trends assumptions held. So if you look at all of these the figures that I have here to my right, and you look at everything that happens before this blue line. So the blue line is when the policy occurred. And you look at the trends between our yellow bubbles here and our blue bubbles here. The yellow represents Georgia, and then the blue represents our comparison states. In general, you can see that overall, the parallel trends hold, meaning that this line here is kind of parallel to the line for Georgia for the donations and contributions. Similar to a certain extent for total margin, generally for days cash on hand, debt to asset ratio. So we generally saw a parallel trend before the program was implemented. So what did our results show? Our results showed that the program had a positive impact in donations, meaning that following the implementation of the program, donations to rural hospitals increased by almost 700% in Georgia relative to the comparison states. The overall financial health of the hospitals also increased. Hospitals who participated in the program in Georgia reported or had a 23% increase odds of excellent or good financial health. There was also a 6.7-point increase in total margin for Georgia hospitals compared to other rural hospitals. We did not find a statistically significant association for days cash on hand and debt asset ratio, as well as the age of fixed plans. However, when you look closely at the trends over the period, you see that even for the ones that were not statistically significant, we do observe a trend in the right direction. So for example, when you look at debt asset ratio to my top right over here, you see that in the post implementation year, which is period 1 and 2, we see a decline. It's not a significant decline, but we definitely see it moving in the right direction. Days cash on hand, we want it to go up, and we see a slight increase. Age of plans, we want it to go down, and we do see a decline. It's just not statistically significant. So we definitely see trending in the right direction, even for those indicators that did not achieve statistical significance. So overall, the program has been found to be associated with improvements in financial health. However, the long-term impact of the program is still in question. And this in part due to recent tax changes that impacted donations, notably in 2019. So the Tax Cuts and Jobs Act of 2017 went into effect in 2019. However, what it did was it increased the standard deduction for individuals who were filing taxes. And so this reduced significantly the number of taxpayers who itemize their taxes. Now, we know that for those who itemize their taxes, they're able to claim charitable donations as part of that itemization. But if you're not itemized, then claiming charitable donations becomes less important or less beneficial to some taxpayers. So there was concern that this would decrease the amount of people that actually donate to the tax credit program or any charity for that matter. In addition, the specific group of high income earners who tend to face an alternative minimum tax, for this group of people, the ability to claim both the state tax credit and the federal charitable deduction made it attractive to donate to the Rural Tax Credit Program. However, the Jobs Act of 2017 also reduced the proportion of Americans who will be subject to this AMT. So there was concerns that this would impact donations as well. So when we look at donation trends, you can see that dip happening in 2019. So the annual cap is 60 million. In 2017, the first year of the program, there was just under 10 million that was received. So we did not get anywhere close to the cap, but we were really close to the cap in 2018. There were 54 million or so reported through the Georgia Heart program. In 2019, that dipped to 46. And then in 2020, that went back up. As of September this year, we have actually already met the cap. And I think that could be in part because of the COVID has brought attention to the importance of hospitals and the availability of emergency care. So maybe this increase in community awareness may have contributed to people just being aware of the program and being willing to support their rural hospitals. This is just speculation at this point. There needs to be further study to look at this and see if the COVID pandemic had any impact in sort of the increase in donations that we've seen in 2021. So another thing that could impact the program sustainability going forward is the taxpayer. So the program really is pivoted on the benevolence of the Georgia taxpayer. So if we donate, the program works. If we don't donate, there's no donation to give to the rural hospital. And part of what would influence this is whether or not people are aware about this program and are willing to donate. We conducted a survey of one rural community in Georgia in 2018, and 73% of the people who took that survey had heard about the tax credit program, but only 45 people then were willing to donate. And among those who were willing to donate, a greater proportion, they tended to be older, white male, employed, educated, and affluent citizens. And they were the ones who had heard about the program and they were willing to donate. And I'm not sure how many of you on this call were aware of the program before the presentation today. So Georgia's approach is unique, but it's not the only approach. There's been increased attention to rural hospitals nationwide, and several states are doing different things. For example, Pennsylvania has implemented a multi-payer global budget model whereby they pay rural hospitals a global budget. And the whole idea is to give rural hospitals predictable revenue and hopefully preserve hospitals, but also assure that there's quality access to healthcare to rural residents. Texas recently increased their Medicaid inpatient rates specifically for rural hospitals. Oregon is looking at transitioning their rural hospitals to a cost-based reimbursement structure, similar to what we see for critical access hospitals. Kansas is trying to encourage their rural hospitals to think outside the box and look beyond the inpatient care and explore alternative modes of healthcare delivery with an emphasis on primary care. The federal government is in as well. There's been a lot of attention that has been brought to rural hospitals, especially in the midst of COVID. The Biden administration has set up specific programming. For example, the chat model actually began in the Trump administration, but it is sort of a grant funding to allow rural communities to test different or innovative rural transformation models that will ensure access to healthcare for rural communities. There's been a lot of money that has been targeted specifically to rural hospitals for COVID testing, but also for in a way to kind of support their financial viability. There are other federal programs like the Flex Grant program that I spoke earlier about, which our team works on for the state of Georgia. There's also the Small Hospital Rural Transition Program, the Small Hospital Improvement Program, that kind of it's specifically targeted to rural hospitals and supports rural hospital services and programming. So in conclusion, there's ongoing state level efforts that are targeted at improving rural hospital sustainability. And all of these efforts, including Georgia's own tax credit program, may provide some lessons for other states and also sort of the national policy agenda when it comes to rural policy. Research such as sort of the body of work that we have conducted here at the Center for Public Health Practice and Research would inform these discussions. For example, our work has already started informing some of these discussions. And this year, in May 2021, the American Hospital Association cited our work looking at the Rural Tax Credit Program in sort of their whole specific look into rural healthcare and rural hospital sustainability. So as we move forward, our current work and our future research activities will continue to monitor rural hospital performance and explore effective strategies for assuring high financial performance, high operational performance, and high clinical performance. So with that, I will pause here and see if anyone has any questions, any thoughts, any comments. And if you're interested in donating to a rural hospital as part of the tax credit program, be sure to talk to your tax advisor about your own specific tax situation. So I will pause and open it up for questions. Thank you all for your attention.
Thank you so much, Dr. Apenteng. So if you have questions, you can either unmute yourself and ask or hit the raise your hand button, and we will try to make sure that we attend to that. So what we'll do is that if you hit the stop the sharing part so we can have the grid look. Thank you. And then we can go from there. So please unmute yourself or raise your hand if you have questions. Okay. So we had just one comment in the chat. Great presentation. And yeah, okay. More than that. Okay. Several people have commented it was a great presentation, Dr. Apenteng.
Thank you.
So we have one question that do you know what residents are doing when a hospital closed?
Could you repeat that, please?
Yeah, so the question is, do you know what residents are doing or what residents do when a hospital closes?
Great, that's a great question. And I think part of what happens after a hospital closes kind of depends on the disposition of the hospital after closure. We are seeing some hospitals not close completely, sort of shut their doors and be gone, but rather they convert into another delivery form. So for example, some will close their inpatient and keep the emergency department open, or some closes everything but transitions to a rural health clinic, or focus more on a nursing home or rehab services. So those sort of, I would like to call like soft closures, tend to preserve a little bit of healthcare access. But when it closes completely and there's nothing else that is available, rural residents then tend to have to out-migrate basically and seek healthcare in other communities. It's been argued though that before a hospital closes, we often tend to see declines in utilization anyways. So it's been argued that the people that are already were already leaving, so the closure shouldn't really affect them as much. But the problem though is the vulnerable population, particularly those who do not have transportation, who were relying on the hospital in the first place. They tend to be worse off because they weren't leaving in the first place, but now they have nowhere else to go because they don't have the resources to be able to seek healthcare elsewhere.
All right. So, okay, that looks, okay. So I think that's it, Dr. Apenteng. So first of all, on behalf of our office and in our college, we want to thank you for your excellent presentation, well received. And we want to remind everyone that the presentation itself has been recorded and the recording itself will be posted no later than tomorrow on our website, as well as the slides that Dr. Apenteng hopefully will share with us. We want to let you know that our next list is we'll hear from Dr. William Mays. Please look out for the announcements related to our seminars, as well as our colleague seminar, that is the B seminar that Dr. Fung runs, and we appreciate that. So Dr. Apenteng, again, on behalf of everyone, we want to thank you for your time and your excellent insightful presentation, and we want to thank everyone for good turnout today, and thank everyone for spending time with us. And we'll see you hopefully at our next seminar in about 2 weeks. So thank you for your time and enjoy the rest of your week. Thank you.
Thank you everybody for attending.